Hello, everyone. My name is Michael Burdi, and I'm an orthopedic spine surgeon with Community Orthopedic Medical Group. The title of my talk today is Spinal Fusion in the Outpatient Setting with a Less Invasive Cortical Pedicle Screw Lumbar Surgery Technique. This presentation is not about screws and cages or another implant talk. The cortical approach is using a cortical screw platform as a means for educating patients and surgeons on outpatient, 23-hour, and short-stay lumbar fusion surgery. The goal of the course is to incorporate both the technique and the economics of this type of surgery, and it can create a unique niche for surgeons that benefits patients tremendously. Trends in surgery and spine surgery specifically are moving cases to the outpatient surgery center or shorter hospital stays. Outpatient, 23-hour or short stays offer significant savings versus an inpatient stay. And these savings can be realized in both outpatient ambulatory surgery centers as well as the hospital setting. Patients and payers both benefit. CMS is moving toward outpatient and ASC short stay surgeries. In 2015, they introduced several codes for anterior cervical discectomies and fusions and laminectomies to allow these cases that were historically done in an inpatient hospital setting to be done in ambulatory surgery centers as well as the hospital in an outpatient or overnight short stay setting. As I'm alluding to, even short stay settings in the hospitals can benefit patients and payers over a protracted inpatient stay. How do patients benefit? Well, a smaller incision leads to less pain, less postoperative narcotic usage, shorter stays, which leads to decreased costs, as well as lower infection rate with a shorter procedure time and stay. Payers benefit with significant savings versus inpatient stays, and it also minimizes hospital complications with extended stays. Longer inpatient stays increase the cost of services because of the numerous ancillary services that are utilized during a longer stay. The cortical approach is not a novel technique, but a traditional open midline approach that uses a different trajectory of the screws to allow the surgery to be done much less invasively. The problem with some newer MIS, as they are called, or minimally invasive surgery techniques, is they have distinct codes, which payers do not often pay because they are seen as experimental. And experimental means non-coverage. However, this approach uses the same midline technique and the insertion of screws, but it's just the trajectory that is different, allowing the surgery to be coded in the same way and to allow a less steep learning curve for surgeons. So what is the cortical trajectory? Cortical versus traditional trajectory is an inside out or medial to lateral caudal to cephalad screw placement, as can be visualized here in the slide. This is for demonstration purposes only, and the screw diameter that we use is oftentimes larger, more analogous to the traditional technique. But the pull-out strength for this trajectory is actually better with a smaller screw than it is with a larger screw placed in a traditional screw technique, which one sees here on the right. For example, a 5.5 millimeter cortical screw will have the same pull-out strength as a 6.5 traditional screw of longer length. The cortical trajectory, as I alluded to in the last slide, is basically going from medial to lateral and from caudal to cephalad, meaning from inferior to superior. This technique allows purchase into better bone, stronger cortical bone, which is better in regular patients as well as osteoporotic patients. What makes the cortical trajectory better? Well, it allows the surgeon to do the surgery through a much smaller midline incision because the screws are being aimed from medial to lateral, as opposed to lateral to medial, which requires a much longer incision. This leads to less tissue dissection, easier tissue retraction, and the medial to lateral approach is easier because there is less resistance from the normal tissue. Other benefits include shorter time for the exposure, less blood loss, shorter stays, a safer technique because you're going away from the nerves, and better bone purchase in osteoporotic bone because you're traversing multiple cortical surfaces, which is stronger bone than cancellous bone. This is an example of a case I did where a 2-level decompression infusion was done through a 6-centimeter technique, and the patient was discharged less than 20 hours after the surgery. The requirements of a cortical system include modular screws, which means that the screw and tulip, which is the top of the screw, is separated so that you can visualize better before you place the tulip on. A pop-on tulip, variable depth drilling because you're going through harder bone, careful cortical tapping because the bone is harder and requires tapping, and a screw head reamer that allows removal of bone around the screw head before the tulip is placed because the tulip or the screw comes in 2 parts. Neuromonitoring is also used as it is in traditional cases. This is another case example of a 56-year-old female with foraminal and central stenosis and an unstable spondylolisthesis that had her surgery done along with a much larger decompression above and below through a small 6.5 centimeter incision and discharged the day after surgery with complete resolution of her pain. And she has significantly less back pain in comparison to traditional surgery, which would have involved a much longer incision. Many times these patients can go home the same day. So why use this platform? It helps patients pursue a surgery in an ASC or short stay setting, which is short stay hospital setting, which is favorable over an extended stay. It's greater suitability to shorter stays and greater patient satisfaction because the surgery itself is less painful and their stay is less. You use many of the same instrumentation as you would with a traditional case, and this does not involve any specialized training in regard to the approach because it's a standard midline approach. The cortical system can be used with either a cortical or traditional trajectory when a patient's anatomy requires a traditional trajectory to be used. So in other words, you can still put in screws the old way if necessary. So in summary, there is a paradigm shift toward moving spinal surgeries to either an ambulatory surgery center or an outpatient or 23-hour stay setting in a hospital. And this is gaining momentum with patients, payers, and surgeons alike. It's ideal for patients and surgeons looking to transition to an outpatient setting or an outpatient practice, as it involves less rounding and less time with extended stays. And unlike many MIS systems, the small yet open midline incision allows for traditional coding and traditional techniques. There are also potential significant cost savings for all involved, including patients, payers, surgeons, and facilities. In conclusion, then, the cortical screw technique education needs to stress both the technique itself as well as the economic benefits of this novel approach to pedicle screw placement. Patients, surgeons, payers, and facilities can all benefit from less invasive surgeries with shorter length of stays, less complications, less pain, and potential cost savings. And that is the end of my presentation.